Hello, can you hear me?
Yes, we can hear you.
Okay, that's good. Okay. So let me check the time here. It's 2 o'clock. I'll wait a minute or two and then we'll see if I could get this thing recorded. Hope I can find the record thing. How do I record? Okay, I believe we're being recorded now. Everybody okay so far?
Yes, it's recording.
Oh, okay, let me share. Let me share my PowerPoint. Let's see. Okay, what do you see right now? Do you see a full screen PowerPoint that says histology review on there?
We see your PowerPoint in speaker view.
Speaker view. Okay, let me see if I could change that. Hmm. How about now? Do you see a full screen?
Still in speaker view.
Still in speaker view?
Mm-hmm. That's okay though. If that's what you need to do.
I changed setting. I mean, I changed it so it's okay. Let's try again. Let me try one more time. Display, swap presenter view and slideshow. That's what I'm doing right now. Okay.
Mm-hmm.
What do you see? Do you see the full screen PowerPoint?
No, it's still presenter view.
Oh, that's strange. I did swap. Okay. Well, um, that's weird. I'm not sure how to fix that because I did the only thing I know. Try one more time. Do you see a full screen PowerPoint yet?
No, sir.
No. Okay. Well,
You can do it from there. That's
yeah,
okay.
that's what I'll do. I can't do any more, but there's nobody here to help me, I don't think. So, um, it's not distracting not to have the correct screen. Is that right? No, it's not distracting. Do you see my arrow?
Can you move it again? Let's see. Yes, we see something moving.
Okay. Okay. So hopefully this will work. All right. Let's go ahead then. Okay. So I'm reviewing ear histology. That's the only thing we have for histology in this next exam. So that's good from your standpoint, I think. Just one thing to worry about. So let's do a little bit of overview at this point. Here's a picture showing you the ear. The ear consists of an external ear, a middle ear, and an inner ear. The external ear is what we see on the outside. We see the auricle or the pinna, which gathers the sound waves that are occurring in the air and funnels them into the external acoustic canal or meatus, which is also part of the external ear. And the external acoustic meatus is lined by skin which possesses glands in its sebaceous glands, hairs, I should also say, hairs, sebaceous glands, and a special type of gland, which is a modified apocrine sweat gland called a ceruminous gland. Together, the secretions of the sebaceous gland and of the apocrine sweat gland, which is the ceruminous gland, along with desquamated epidermal cells, I suppose, together form earwax, cerumen, which you don't see in this picture, thankfully. And then limiting the external acoustic meatus is the eardrum or tympanic membrane, which vibrates according to the pressure waves moving through the external ear canal, transmitting the sound waves from the external ear to the middle ear. So here we have the middle ear, in which there are three very tiny bones which are linked together, called the auditory ossicles, which are quite well known. I think just about everybody knows about them. The malleus, incus, and stapes, hammer, anvil, and stirrup, stapes, okay, which are like levers. They transmit the vibrations initiated by sound waves in the air to the inner ear, and by acting as levers, they help amplify the sound wave vibrations. Actually, the way the external ear is set up with the earlobe and the external auditory meatus, the sound waves are gathered. They maintain they're in a way amplified by being gathered into a narrow canal, and then the eardrum gathers them further and transmits the vibrations in the air, the ossicle chain, which then transmits the vibrations to the inner ear. The tympanic cavity in which the ossicles are located is filled with air at atmospheric pressure. The reason why it's filled with air at atmospheric pressure is that it's linked to the nasopharynx via the auditory canal, here also called the eustachian tube. Normally the tympanic cavity is filled with gas, not with fluid. When you have otitis media, fluid accumulates, and some other problems as well. Fluid may accumulate within the middle ear cavity or tympanic cavity. There is a mucosa which lines the middle ear cavity. Right here, you don't see the mucosa particularly in this particular illustration, but it's a simple epithelium, a simple squamous or cuboidal epithelium, and that's continuous with the epithelium within the auditory tube here, or eustachian tube. The eustachian tube, as you recall, ends at the nasopharynx, discharges at the nasopharynx. The nasopharynx is part of the respiratory system, lined by a respiratory epithelium, which is pseudostratified columnar epithelium. So the lining epithelium of the auditory tube is pseudostratified columnar epithelium with cilia and goblet cells, just like other areas that are lined by respiratory epithelium. That's important to know for some disorders that affect the tympanic cavity. Otitis media, for example, may affect the tympanic cavity. And that has something to do with the way that the auditory tube is constructed. We'll talk about that more later. The inner ear contains a very complicated structure, which we see here. It's very recognizable on a glance, but it's quite complicated. We'll talk more about that in a second here, but this is a series of cavities within the temporal bone at the base of the skull. What this is really a series of connected cavities. In order to see this type of snail-like and other associated structures, you need to really inject material within these cavities to form a cast of the lumen, and you get something that looks like what you're seeing right here. It's not that these exist as freestanding structures. They are cavities within the bone, and they can be visualized in the way they are demonstrated here by injecting material within these spaces and getting a cast. That's what you're seeing. So to get a better sense of what the inner ear looks like and how it's constructed, we can look at something like this. There are three diagrams in this particular image. And if you look at these three diagrams in sequence, it helps you understand how the inner ear is constructed. On the left-hand side, we see basically a cast of the bony labyrinth. So there's a series of interconnected cavities within the temporal bone, which make up altogether the bony labyrinth. The walls of this space consist of the actual bone of the temporal bone. The bony labyrinth actually consists of three major parts. The part that looks like a snail is the cochlea. It's actually the bony cochlea, okay? But we usually just say cochlea. On the other side, this is actually facing more anteriorly. The cochlea is more anterior in its location. Posteriorly located are these three semicircular canals. These are bony semicircular canals. We usually just say semicircular canals. And communicating with both the cochlea, the bony cochlea, and the bony semicircular canals is the vestibule. This space here is the vestibule, which the walls of the vestibule, just like the walls of the other spaces, are aligned or covered by bone. So altogether, this is the bony labyrinth, consisting of these three major parts. By the way, opening up into the vestibule, here you see the oval window, the stapes of the middle ear ossicles, the foot plate of the stapes inserts into the bony vestibule right here. And exiting from this region, it's not quite the same spot as the oval window. It's more towards the cochlear end. Here is the round window, which you see down here. So here's the oval window, here's the round window, which is actually closer to the cochlea than it is to the vestibule. Okay, so the ear then consists of a bony labyrinth. Now, inside the bony labyrinth is suspended a membranous labyrinth, which is a very thin membrane composed of epithelium and a very thin layer of connective tissue underlying the epithelium. So here in the middle, we see an illustration of the membranous labyrinth contained within the bony labyrinth. Now, when we talk about the cochlea, inside the bony cochlea, or bony labyrinth, I should say, altogether these various canals and cavities or spaces are sometimes called a labyrinth. So inside the bony labyrinth of the cochlea is the membranous labyrinth of the cochlea, and that's called the cochlear duct. So here we see the bony labyrinth, if you will, of the cochlea, and inside that is the membranous labyrinth or cochlear duct. Okay. On the other side, here we have the vestibular labyrinth. We have the three semicircular canals with an outer bony labyrinth, and inside that is the membranous labyrinth of the vestibular part of the ear. And these are called semicircular ducts. These are ducts inside the bony labyrinth. So this membranous part of the vestibular apparatus are called the semicircular ducts. And inside the vestibule, which is this central region here, the vestibule of the bony labyrinth are these membranous spaces. There are two sac-like spaces called the saccule and the utricle, saccule and utricle. So those are the two parts of the membranous labyrinth within the bony part of the vestibule. It so happens that the semicircular ducts both arise and terminate in the utricle. So here's the utricle, and you see the semicircular ducts arising and terminating in the utricle. In actuality, all of these structures of the membranous labyrinth are interconnected. So if there was a problem in one part of the membranous labyrinth, it may affect other parts of the membranous labyrinth as well. There are certain disease processes which affect the entire membranous labyrinth, the labyrinth which belongs to the auditory system and the labyrinth which belongs to the vestibular system. Now, in the third picture here on the right-hand side, you see some certain specialized sensory regions of the membranous labyrinth. So if you talk about the cochlear duct here, the auditory labyrinth, there is a spirally shaped sensory epithelium which travels along or follows along pretty much the entire length of the cochlear duct. This spiral-shaped sensory epithelium is called the organ of Corti. It's lightly demarcated in this image, but if you look very carefully, you see this spirally shaped sensory epithelium, which is called the organ of Corti within the cochlear or auditory labyrinth. And then if we look on this side here, in the vestibular labyrinth, we see several different types of sensory epithelia which mediate the vestibular sensation, if you will. Within the semicircular ducts are these transverse ridges of epithelium right here and right here and right here, which are called the crista ampullaris. So here's the crista ampullaris of the anterior semicircular duct. Here's the crista ampullaris of the lateral semicircular duct. And here's the crista ampullaris of the posterior semicircular duct. As you can see, there are three separate cristae ampullaris within the semicircular ducts. In actuality, there are within a dilatation of these semicircular ducts. You see here, there's a dilatation just before the semicircular duct joins the utricle here. You see how them joining the utricle? This dilatation is called the ampulla of the semicircular duct. So here's an ampulla of a semicircular duct, here's an ampulla of a semicircular duct, and here's an ampulla of a semicircular duct. And within that ampulla is this transverse ridge, which is elevated, an elevated transverse ridge, which is called the crista ampullaris. Now, there are two membranous sacs of the membranous labyrinth in the central area here. This would be the bony vestibule region. So within the bony vestibule, you have these two membranous sacs. One sac, as we mentioned just now, the utricle, that's a membranous sac, and here's the other sac called the saccule. Each of these sacs contain a spot-like area of sensory epithelium, which are, involved in perception of balance and equilibrium and so on. And these are called the macula. So here's the macula of the saccule right there, and here's the macula of the utricle. So putting it all together, there's 1, 2, 3, 4, 5, 6 different sensory areas within the membranous labyrinth. The organ of Corti mediates cochlear sensation or hearing. The other sensory epithelia, which we mentioned, mediate senses of balance, position of the head, movement of the head, whether it's linear movement or angular movement, those type of things. All these things together you might simply call vestibular sensations. They're part of the vestibular apparatus of the ear. Okay. Let's talk about the cochlea a little further. If you take an ear and transect it, the inner ear that is, you see the cochlea. This is what the cochlea looks on transverse section. Actually, the cochlea externally looks like a snail. It's a longitudinally oriented tube that spirals around itself, forming about 2 3/4 turns. So if you were to transect the cochlea, you would see multiple turns of the cochlea within that transection. So here we see basal turns within the cochlea. Here we see the apical turn of the cochlea, and here we see the middle turn of the cochlea, all together forming the 2 3/4 turns of the cochlea. Now, if you look at the spaces within each of those cochlear channels, you would see that it's actually subdivided into 3 separate chambers in a sense, three chambers. The upper chamber sometimes is called the scala vestibuli. This chamber carries sound waves from the round window. Remember that the footplate of the stapes inserts into the round window, and when it vibrates, it transmits vibrations into the fluid contained in the scala vestibuli, and the scala vestibuli ultimately will become connected at the apex of the cochlea with this bottom chamber right here, which is called the scala tympani here. The scala tympani carries the sound waves within the fluid within the scala tympani and vibrates. And the spent vibrations or spent waves within the scala tympani are discharged at the round window. Now, there's a fluid contained within the scala vestibuli and scala tympani, which is
Dr. Brown,
yes.
we cannot see your mouse. I can guide you to remove
You
that
can't see the mouse?
presenter view. Yeah, so on the bottom left of your screen, do you see this circle with 3 dots in the center?
Bottom. I don't see a circle.
It's right next to the thing that looks like a camera, right under the presentation.
Press that.
I cannot see your mouse, but yeah, so if it's a circle with 3 dots, press that.
Press. Okay.
Yes, now select arrow options
Okay.
and then say visible.
Okay.
Try move around. Oh, well, I tried. Sorry.
It doesn't
Didn't
work?
No, I
Does it
cannot
work
see
now?
it. Oh, no, there. Now we can see it. Okay.
Okay.
Sorry. Thank you so much.
Okay. See this, okay. This has a different kind of screen on it that, so you're seeing all kinds of maybe extraneous stuff on this screen, perhaps. This screen is okay for you to use?
People received a message that they want to keep it.
You want it? Okay.
We're fine.
We'll just leave the screen. I'm not sure what you're seeing, but since the mouse works here, we'll do it. Okay. So anyway, so the scala vestibuli, scala tympani contain perilymph. And then there's a third space called the scala media. The scala media is actually the actual cochlear duct. This is the actual cochlear duct, which transmits sound, which is responsible for the stimulation of the organ of Corti. So there's 3 linear channels within the bony cochlea. The scala vestibuli, scala tympani, which contain perilymph, and the scala media, also known as the cochlear duct, which contains endolymph. Endolymph is quite similar to intracellular fluid, high in potassium, low in sodium, whereas the vestibuli, tympani are more like extracellular fluid, high in sodium, low in potassium. So these are 2 different fluids, and they have different ionic compositions. Here you see the same thing in actual histologic section. Here you see scala vestibuli, scala tympani. They're fairly large channels. This fairly small channel here, it looks rather angular. See how angular it is? This is the scala media. This is the actual cochlear duct. The actual cochlear duct, which contains the organ of Corti. Here's the organ of Corti, and it's based right there. This area here, you have to look very carefully to see it, is the organ of Corti. In this drawing here, here's the organ of Corti right there. Okay. There's a lot of details in here. I'm not going to go over all the details, but this gives you the basic outline of what you see in a transverse section of the cochlea, and the actual cochlear duct per se is also known as the scala media, which contains the organ of Corti. Okay. Oh, why didn't it advance? I have to go here. The image didn't advance on the side. Let's see if I can. I have to move my mouse see, back to the other screen because this is not advancing now. Let me see if, let me just give me one more moment to see if I could get this to
Try exit presenting mode for a second. Just press escape on your keyboard.
escape on my keyboard. Okay. What do you see now?
And now we'll go back into presenter mode. It will be on the bottom right of PowerPoint. And it looks like a video projector, like a screen projector.
I'm looking at video projector.
Do you see something on the bottom right of the PowerPoint that looks like that has a sliding scale that says a percentage? Like
No,
100%.
no, I don't see that.
On the bottom of your Zoom, there will be something that says share.
Okay, I have share.
Yeah. So there on you can select share, and there will be options such as share your whole screen or share only one window, which might say PowerPoint.
Well, let's try this.
There we go.
What do you see? I'm not. Do you see my arrow by any chance?
Yes, we do.
You do.
And now
Okay.
on the very bottom right of that screen, very, very bottom right.
Well,
Do you see that's
I have it right in the middle of my presentation.
I'm gonna highlight it for you. Like right there, somewhere right there.
That's where you see my arrow?
No, that's where you will go back to presenter mode in PowerPoint.
So press this.
Yeah.
Okay, what do you see now?
We can see the presentation as it was before, so we're good, I think.
Okay, okay. You see my arrow?
Why don't just go like
Yes,
push
we do.
Okay, all right. Let me just move ahead then. Okay, so this is just an organ of chordae and higher magnification. It's this area of sensory epithelium. It's actually a transverse section here, but it's actually a spiral in 3 dimensions, and it's complicated, but to make it simple, it consists of hair cells, which are the sensory cells, and support cells. That's basically it, hair cells and support cells. And on top of the hair cells, which contain on their apical surface stereocilia, which are the sensory hairs actually. They're long microvilli, which are actually sometimes called stereocilia, and they insert into this acellular membrane here called the tectorial membrane. See how these are hair cells right here? They insert into the tectorial membrane, which is an acellular membrane. So when there's vibration of the base of the organ of chordae, this is actually the basilar membrane of the organ of chordae. When that vibrates, because there are sound vibrations coming through the cochlea, the hair cells vibrate along with their stereocilia, which are inserted into the tectorial membrane right here. And that causes depolarization of the hair cells, and they transmit a neural impulse at that point. They transmit a neural impulse. So in this way, the mechanical changes of the sound waves are transformed into electrical impulses to the nervous system. Okay. Let's talk about the vestibular apparatus. Here we see, again, the inner ear, and here we see in the vestibule portion of the inner ear, we have these 2 sac-like organs, the utricle and the saccule. They're both parts of the membranous labyrinth, and in their wall is a spot-like area of sensory epithelium called the macula of the utricle and macula of the saccule. Each of them have these hair cells like this, which have upon them a tuft of hairs. A tuft of hairs actually consists of stereocilia. They're not really hairs, they're really stereocilia. And they're interesting because they're very well organized. They're highly organized. They're organized like a series of steps. One stereocilium is taller than the row in front of it, and then behind that there's another row of stereocilia which are taller yet, and behind that is another row of stereocilia which are taller yet. So altogether they have a step-like configuration going from relatively low to relatively high. And when you're talking about the vestibular apparatus, behind the tallest stereocilia is a modified true cilia, not a type of microvillus, which is what a stereocilia is, but the actual modified true cilium, and that's called a kinocilium. The kinocilium is actually a true cilium, which may be slightly modified for the vestibular apparatus. So putting it all together, a hair cell looks something like this, with this graduated collection of stereocilia, which are the hairs, and together they form a hair bundle or hair tuft, if you will, and behind them is a kinocilium. Now, if you look at the macula of the utricle and saccule, they have an additional specialization. They have these calcium carbonate crystals. Here is a scanning electron micrograph showing you the calcium carbonate crystals, which are called otoliths or otoconia, right there. If you look at a light microscopic view of that, it looks something like this. This is the sensory epithelium containing hair cells. It's really hard to see the detail of the hair cells here, but there are hair cells right here. And at the base, you're going to have many support, the nuclei of support cells as well. So there are hair cells and support cells in this epithelium. Then overlying that is a gelatinous membrane. The gelatinous membrane sometimes is called an otolithic membrane because contained within this membrane are these calcium carbonate crystals called otoliths. Here you see the darker staining bluish material here. These are the otoliths, which are embedded in the otolithic membrane of the macula and utricle. The only place where you see an otolithic membrane are the macula of the utricle and saccule. You do not see otoliths in the organ of Corti. You do not see otoliths in the sensory epithelium within the semicircular canals, the crista ampullaris. You do not see otoliths there either. The only place where you're going to see the otoliths is in the otolithic membrane of the macula and utricle. Okay. Here we see the crista ampullaris of the semicircular canals. These are the sensory areas in the semicircular canals. And you see this acellular membrane covering the surface of the crista ampullaris. It's quite tall. It reaches actually across the entire width of the lumen, from the base of the lumen, in a sense, to the apex of the lumen right there. These are hair cells and also support cells making up the crista ampullaris. The sensory hairs of these hair cells are embedded within the cupola. The cupola is a gelatinous membrane, just like the otolithic membrane, which is a rather gelatinous membrane. Now, to summarize some of the functions here, the crista ampullaris of the semicircular canals responds to angular acceleration of the head, or rotational movement of the head. Okay, so angular or rotational movements of the head cause action potentials in the hair cells of the crista ampullaris, because the crista ampullaris are occurring in the three semicircular canals, which are located at right angles to each other. Your body is able to actually sense angular acceleration in any of the planes of three-dimensional space. In contrast to that, the macula of the saccule and utricle do not sense angular acceleration. What they do sense is linear acceleration, So if someone is going laterally in a car in a straight line, the macula of basically the utricle and saccule will perceive the linear acceleration occurring in a straight line in a car. Also, if you're going up or down in an elevator, the macula of the utricle saccule will sense the linear acceleration, the vertical up and down, the straight up and down within an elevator. So this is important to know. In the semicircular canals, angular acceleration sensed by the crista ampullaris, and the utricle saccule, linear acceleration in the macula of the utricle and saccule. Also, the utricle saccule, important for sensing the acceleration caused by gravity, pulling us down to the center of the Earth, is linear. So the utricle saccule, not just linear acceleration, straight up or down or laterally, but also the pull of gravity in a linear fashion towards the center of the Earth is sensed by the macula of the utricle and saccule. Okay, this is just a summation of that here. You see here some key histologic features of the membranous labyrinth, which we already talked about, so I won't say much more about it. It just summarizes it. Let me just state this again, because I think it can be confusing. Semicircular canals can contain crista ampullaris, and the acellular membrane sitting on top of the crista ampullaris is the cupola. The utricle and saccule, the sensory regions are called the macula. The acellular membrane on top of that are called generically the otolithic membrane. Those contain calcium carbonate crystals, also known as otoliths or otoconia. And the cochlear duct, which is within the organ of Corti, are covered by what's called the tectorial membrane. That's the acellular membrane covering the organ of Corti. All these structures utilize hair cells and support cells. A little bit more about the external ear. Here's the external ear. Collects sound waves, the vibrations in air caused by vibrating objects in the environment. It concentrates the sound waves and therefore makes it more readily accessible to ultimately to our inner ear for further processing. The canal is called the external auditory or acoustic meatus. It vibrates the tympanic membrane. In a way, the external ear acts like a funnel. The cartilage within the external ear, as you all I'm sure know by now, is made of elastic cartilage. You're able to deform your ears. You're able to tug on them. You're able to move them around a bit, and they snap back into their original shape quite readily because they contain elastic cartilage. So here's a picture of elastic cartilage. The lining of the external acoustic canal or meatus consists of skin with ceruminous glands and sebaceous glands, and those materials make cerumen, which is important for protecting our ear from infection. They have antimicrobial abilities. They keep the skin also, I guess, in good shape to keep it from becoming dry and cracked and so on. These are ceruminous glands. They're modified apocrine glands. So the apical part of the cytoplasm is sloughed off into the lumen, which contributes to formation of cerumen. Here's a tympanic membrane. It actually has a histology. The part facing the external auditory canal is lined or covered by stratified squamous epithelium, the kind of epithelium that's found in epidermis, keratinized stratified squamous epithelium. The part that lines the tympanic cavity is lined by a simple cuboidal epithelium, which we see right here, simple cuboidal epithelium. It's actually part of the mucosa of the tympanic cavity. In the center, actually the thickest part of the tympanic membrane is fibrous connective tissue. In other words, collagen. Here you see well-organized, dense collagen, fibrous connective tissue, which makes the tympanic membrane strong, gives it great tensile strength. Why do you want the tympanic membrane to have great tensile strength? Well, you want it to resist mechanical trauma. If there's a sudden loud sound in the environment, it could rip the tympanic membrane if it wasn't strong. If the external pressure changes rapidly, let's say you jump out of an airplane with a parachute, or let's say you go diving, during diving or skydiving, or I guess marine diving, by rapid changes in pressure, it may tear the tympanic membrane. So you need a strong, and cause hearing loss, by the way. So to prevent that from happening, you have a strong tensile strength in the tympanic membrane. In the middle area of the three ossicles, as we mentioned, this is a air-filled cavity that equilibrates with atmospheric pressure. It's lined by a simple cuboidal mucosa. It's in continuity with the nasopharynx and external atmosphere via the auditory tube or eustachian tube, which is lined by respiratory epithelium. Respiratory epithelium has cilia. It's ciliated. It's pseudostratified columnar epithelium and contains goblet cells. So if you have some process which causes dysfunction of cilia, it cannot sweep unwanted materials, including mucus, from the tympanic cavity towards the nasopharynx. So that's one of the reasons that people get infections if something impairs ciliary action. If there's something wrong with mucus, if it's too thick or dense for some reason, there may be blockage of the auditory tube because the mucus gets too thick or abnormal. So a well-functioning auditory tube is important for normal hearing. Here's the inner ear, and it's a complex structure, as we already looked at, and it consists of several different elements. And I won't go over them again in the same detail, but when you look at this, certainly you see the hearing apparatus, auditory apparatus consisting of the cochlea, and you have the vestibular apparatus, that part of the inner ear, which is responsible for assessing circular acceleration, linear acceleration, and the head's orientation with respect to gravity. All that occurs via the semicircular canals and via the utricle and saccule of the vestibule, which is the central region of the labyrinth right here. Here we see the vestibular complex on this side of the diagram, and here we see the cochlea on this side of the diagram. Okay, here we see another histologic image and also a drawing of the cochlea on cross-section. And it's not a full cross-section here, but usually it's easy to make out the cochlear duct, also known as the scala media, because it's relatively small, but also angular looking. See here in this image here, it's very angular looking, like this, it's angular. The base of the cochlear duct consists of the basilar membrane. The roof of the cochlear duct consists of the vestibular membrane right here. It's called vestibular membrane or Reissner's membrane right here. Sitting on top of the basilar membrane is the organ of Corti, which is where the sensory epithelium that senses sound is located. This complicated structure here is the organ of Corti. It has a rather complicated structure, which you don't need to know every detail about, but realize there are going to be those sensory hair cells, which are mechanotransducer cells. They transform mechanical vibrations into electrical nervous system impulses. That's what hair cells do in general. in the inner ear. They do that for the organ of Corti, but they also do that for the vestibular apparatus of the ear. So both the organ of Corti and vestibular apparatus have hair cells which transform mechanical impulses into electrical impulses. They are mechanical transducer cells. And the same principle, in a sense, or a similar principle, involves both the vestibular apparatus and the auditory apparatus of the inner ear. This upper chamber, of which we see only part, is the scala vestibuli, SV. Here you see the scala vestibuli here. The lower chamber, which we see here, and here in this diagram, scala tympani, scala vestibuli, scala tympani contain perilymph. Scala media or cochlear duct contains endolymph. The cochlear duct, high potassium, low sodium. The perilymph and these other compartments contain high sodium, low potassium. Those ionic features are important for the proper functioning of the inner ear. That's why they're important. Okay, we talked about this, so I don't think we're going to talk further about that. Hair cells of the inner ear, they basically act by a similar plan. As I said to you earlier, they are hair cells containing tall microvilli or stereocilia forming a hair bundle, which is graduated in height, going from low to high, kind of like a series of steps. And behind or adjacent to the highest stereocilium, the highest step is a modified true cilium called a kinocilium. Actually, the kinocilium is found only in the vestibular apparatus. It's not found in the cochlear duct. But basically speaking, the hair cells are very similar between the cochlea and the vestibular apparatus. And these microvilli and the cilium actually are embedded in the overlying acellular membrane. As you know, in the vestibular apparatus, there's an overlying gelatinous membrane. Depending where you are in the vestibular apparatus, the microvilli are embedded in that membrane, and when that membrane is shifted or moves, it creates a nerve impulse in these hair cells. And in the cochlea, these hair cells are also, the hair tuft are also embedded in the overlying tectorial membrane of the cochlea. And so when that vibrates, it creates a signal in the underlying hair cell of the organ of Corti. This is just a summary of those things which we talked about, so I'm just going to move on here. These are things that you have in your materials already. These are not new things for the most part. Almost everything I'm showing you today is something you already have in your classroom materials. So let's talk about a few clinical correlations. After rapid altitude change during parachuting, you might expect there to be a rapid change in air pressure. A patient develops barotrauma. Trauma to the could happen to the ears from change in pressure, barotrauma, with tympanic membrane perforation. This must be rather severe barotrauma to perforate the tympanic membrane, because as you know, with all that collagen in the tympanic membrane, it ought to be quite tough. Which histologic layer normally provides most of the membrane's tensile strength? We've mentioned this already. It's the dense fibrous connective tissue of the membrane. So here's a tympanic membrane with skin facing the external auditory meatus with cuboidal epithelium, which are part of the mucosa of the tympanic cavity here on this side. In the center, dense collagenous connective tissue here, dense regular connective tissue here, giving tympanic membrane great tensile strength. Now, if someone actually tore the tympanic membrane, ruptured it because of barotrauma, it may cause some disturbance of hearing, the loss of hearing. This is called a conductive hearing loss, because the nervous part, the hair cells and the nerves within the inner ear are still and the brain, I should say, as well, is still intact. The nervous system and hair cells, the sensory receptors are still intact, but it's the conduction of the sound waves which is interfered with by rupture of the tympanic membrane. So this is a conductive hearing loss. Here's another question. A 3-year-old child is brought to clinic for recurrent episodes of acute otitis media. So otitis media would affect the middle ear. Media means middle, affecting the inflammation of the middle ear. And there are persistent middle ear effusions. So when you have inflammation, which you learn about in pathology, fluid and cells tend to accumulate in an area that's undergoing inflammation in the process, let's say, of fighting infection. So there will be problems occurring in the middle ear with accumulation of fluid and inflammatory cells, and that would impede conduction of the sound vibrations along the ossicles of the middle ear. That would be presumably a type of hearing loss, which is also a conductive hearing loss. So otitis media also causes a conductive hearing loss. The child lives in a crowded home and is chronically exposed to secondhand cigarette smoke because both parents smoke indoors. Well, when both parents smoke, I know smoking affects ciliary activity. There are not cilia in the middle ear per se, but they are present in the respiratory epithelium of the auditory tube, and the auditory tube is responsible for sweeping fluid from that may be occurring in the ear or in the auditory tube from that region towards the nasopharynx. So if you impair ciliary action, it's easy for inflammatory materials and fluid to accumulate in the middle ear, predisposing to otitis media. So anything which interferes with ciliary activity predisposes to otitis media of the middle ear. Even secondhand cigarette smoke in a child. Because of ongoing infections and hearing concerns, the child undergoes placement of tympanostomy tubes, ear tubes. So dysfunction, which epithelial lining most likely contributed to this child's condition? Well, the pseudostratified ciliated columnar epithelium of the auditory tube. That's what was affected here. Now, if someone had a disease where the mucus was too thick, like cystic fibrosis, the mucus is abnormal, it's too thick, it may also impair function of the respiratory epithelium in the auditory tube as well. So that thick mucus may prevent passage of materials from cleaning out of the middle ear by removing that material that accumulates in the middle ear towards the nasopharynx. So any type of dysfunction of the auditory tube can cause otitis media, not just impairment of the ciliary activity of those cells. Here's a histologic image showing you respiratory epithelium like you might find in the eustachian tube, and here you see cilia on the surface of pseudostratified columnar epithelium. Here you see these goblet cells. Here's a goblet cell, goblet cell, goblet cell, goblet, goblet, goblet. Okay, so in this particular case, this child was exposed to secondhand smoke, which can affect the ciliary activity, and actually irritating the epithelium may actually cause too much mucus production. It may cause, so that may also contribute, I should say, not just ciliary activity, but excess mucus production if your epithelium is being irritated by cigarette smoke. Here we see if you were to examine someone's eardrum by putting a scope into their ear, not a scope into their external ear canal, you would see the tympanic membrane. And if there was fluid and cells accumulating in the middle ear cavity, you may see bulging of the tympanic membrane, like here, for example. And with inflammation, often the area becomes more red because there's increased blood flow. So here you see a bulging tympanic membrane with redness because of, and actually vascular markings, because there's inflammation and increased blood flow through the small vessels of the tympanic membrane. Now, to cure that, someone may put in a tympanostomy tube right there, which allows drainage of the materials within the middle ear. So even if the eustachian tube wasn't able to drain efficiently for whatever reason, by putting a tympanostomy tube, an ear tube in, it helps drainage of the inflamed area accumulating inflammatory fluid in the cells and help eventually cure the process. This usually falls out spontaneously after a period of time. If it doesn't fall out spontaneously, then it could be removed surgically. The type of hearing loss that would occur in this situation by preventing air transmission of auditory sound waves through the middle ear is called a form of conductive hearing loss, not a form of sensory neural hearing loss, which would be due to damage to the inner ear, the organ of Corti, the hair cells, the cochlear nerve arising within the inner ear, traveling in the cochlear nerve to the brainstem, traveling through the brainstem, and eventually to the cerebral hemispheres in the nervous system. Those all would be sensory neural hearing losses. Those are different. Just a little bit more about the pathogenesis of otitis media. There are, besides cigarettes, smoking, which I mentioned to you, cystic fibrosis, I did mention to you, that causes abnormally thick mucus, and that causes blockage of flow of materials within the auditory tubes. Both of those can cause acquired conductive hearing loss, as I mentioned, but sometimes there's also genetic abnormalities of cilia functioning, so also called primary ciliary dyskinesia, where someone's born with a mutation of ciliary protein, which causes abnormally functioning cilia. They don't sweep normally, and again, you get accumulation of materials, which eventually leads to inflammation of the middle ear and hearing loss. Sometimes this ciliary abnormality, primary ciliary dyskinesia, affects more than just respiratory epithelium. It can cause a multi-system dysfunction. The heart doesn't get positioned in a normal position, so it points to the right instead of to the left. These people also may be infertile. Men may be infertile because of abnormal function of the flagellar tail of spermatozoa. That's the type of multi-system syndrome where there's abnormal functioning of cilia. Is called Carter-Gainer syndrome. So all these may be associated with hearing loss if the respiratory epithelium of the auditory tube is affected. A construction worker with years of daily jackhammer exposure develops progressive permanent hearing loss. Which specialized epithelial structure most directly affected? Well, all that trauma from excessively loud sounds. It is traumatic to hear excessively loud sounds. If you suddenly hear a loud bang, it's kind of painful to hear that. It damages the hair cells of the organ of Corti. Those cells are not replaceable. They're end-stage cells. They are not replaceable. So damage to the organ of Corti, what may cause hearing loss. What type of hearing loss? Sensory neural hearing loss. Those are the sensory cells there of for the auditory system. And if they are lost because of excessive noise, you could develop sensory neural hearing loss. And someone who is a construction worker certainly is at risk for developing that kind of hearing loss.
Dr. Braun, do you mind if I ask? Why wouldn't the tympanic membrane also be an answer? Because wouldn't rupturing it also dampen sound, I guess?
Let me see how that's worded. Which specialized epithelium? Well, in theory, you might think of it. I don't know how often merely loud sound, high amplitude sound, will rupture the organ of the tympanic membrane. But I think basically the way the stem is worded, specialized epithelial structure, sounds more like an organ of Corti than a tympanic membrane. The tympanic membrane is a complicated structure with two epithelia on either side and a central layer of collagen. It is more than just a specialized epithelial structure. In fact, the epithelium on both sides of the tympanic membrane are not so specialized. One is like epidermis of the skin, and the other is just a simple mucosal epithelium, like a simple cuboidal epithelium. So that's not quite a specialized epithelial structure either. So at first, if you're not paying super attention to the wording, yeah, it sounds like a great answer, but if you think about it carefully, the only answer which works well, which is clearly the best answer, would be C.
All right, thank you so much for explaining it.
Yeah. Here's the organ cordy, which we've seen before. We're not talking about it in too much detail, but of course know that it has hair cells and support cells, and know that the stereocilia, the hairs of the hair cells, embed themselves into the tectoral membrane, which is an acellular membrane. And when there's shaking of the hair cells, vibration of the hair cells, because the sound wave is being transmitted to the fluid media of the cochlea, the hair cells get the stereocilia get displaced with respect to the tectoral membrane, and that initiates a neural impulse. That's a form of mechano-neural transduction, changing a mechanical impulse into a neural impulse. And that neural impulse is transmitted to the central nervous system for further processing and ultimately what we experience as hearing. A patient has recurrent episodes of vertigo, tinnitus, fluctuating hearing loss, and oral fullness. This sounds like a syndrome, perhaps. Anybody know what syndrome that is? Meniere's syndrome sounds like to me. Meniere's syndrome. These combined symptoms are best explained by abnormal pressure affecting which type of inner ear system? Well, vertigo is a symptom of dysfunction of the vestibular system. When your vestibular system works normally, you don't feel that the world is moving around you inappropriately. You don't feel like you're moving with respect to the world inappropriately. You don't get a sense of dizziness from that spinning sensation. That sounds to me like something wrong with the vestibular system. Tinnitus, that's something wrong with the auditory system. Fluctuating hearing loss, it's also something wrong with the auditory system. Oral fullness, that sounds like there might be too much fluid inside the inner ear. Remember, the inner ear cavities are all fluid inside the inner ear cavities. You may get a discomfort. Here it sounds to me like let's say, the membranous labyrinth of both the auditory system and the vestibular system is affected. And the oral fullness, it suggests to me there's too much fluid within the auditory portion of the membranous labyrinth and the vestibular portion of the membranous labyrinth. Remember, the auditory and vestibular labyrinth are really all interconnected. We didn't talk about the names of those interconnections, but they are all really part of a continuum, and there are some very, very fine connections between them. So it is possible for a disease affecting one part of the labyrinth to affect the other parts of the labyrinth if the disease process spreads. So here's a normal membranous labyrinth within the bony labyrinth, you see. They are interconnected. If you look carefully at these diagrams, you see some interconnections. There's a little interconnection there. There's a little interconnection there. Now, if you look, this is normal on the left-hand side. If you look at the right-hand side, it looks like there's increased volume of endolymph within the membranous labyrinth of both the vestibular portion of the labyrinth, the vestibular labyrinth, and the auditory labyrinth here, this portion of the labyrinth right there. Okay, the labyrinth is expanded, and I presume under greater pressure. So, in this disease, Meniere's disease, excess fluid, for various reasons we may not totally understand, accumulate in the membranous labyrinth, both auditory and vestibular, causing these symptoms, which are often, recurring. They may, recur in episodes and get worse over time. Okay, this is just a summary which you already have in your classroom materials, so I'm not going to go over them any further because you already have them in your classroom materials. If you have any questions, I'll take them from you. Otherwise, that's it for this session.